Come in front so that you guys can answer. This is not a theoretical lecture. I'm just going to put some cases so that you guys can try answering. Get it right, get it wrong, but learn the right thing and go. Shall we start? At least another. Am I audible to the people behind? Please feel free to stop me anytime. For people who don't know me, I'm Dr. Shibu. So welcome to Postgraduate Medical Lecture Series. Today we'll speak about more in terms of an approach, but within the time limits, we will try and see if we can look at thyroid diseases from an internal medicine guy's perspective. Okay. So our discussion, if time permits, we will discuss the whole thing, but if not, when the time ends, till the time ends. So we'll try and go back to the basics, looking at briefly at anatomy, histology, and embryology. Also at a detailed look at hormone synthesis and regulation, how to clinically evaluate a patient with thyroid disease, laboratory evaluation, approach to hyper, and if we have time, I don't think so, but thyroid emergencies and thyroid diseases in pregnancy are two entities you shouldn't forget while you look thyroid as a topic. Going on to the anatomy, as we all know, these first few slides might look a little boring. Thyroid, the word comes from a Greek word which means shield, a form of shield. As we know, it's got two, I'm not using it, it's too difficult to show. It's got two lobes connected by an isthmus. It's a butterfly shaped gland, anterior to the trachea and between your cricoid and your suprasternal notch. The normal thyroid characteristics are roughly 12 to 20 grams in size. It is a highly vascular organ and generally it is in soft in consistency. The vertical extent in terms of spinal levels will be from C5 to T1. Along with this, some people can actually have a remnant of a remnant called pyramidal lobe which extends here. This is not shown in this picture. Looking at histology, thyroid gland primarily consists of the structural and functional unit which is called a follicle. Now this follicle is lined by follicular cells which are simple cuboidal epithelial cells, and these are the cells that produce your principal thyroid hormones. Within the colloidal follicular cells, you have a colloid which is a gel-like mass which contains thyroglobulin, which is rich in tyrosine amino acid. The tyrosine amino acid gives a polarity to the colloid, the cell, apical and the basal. And you also have some parafollicular cells secreting calcitonin, not really relevant in terms of thyroid physiology except for as a marker in medullary thyroid carcinoma. So we wouldn't speak much about calcitonin here. Quickly looking at embryology, a few key points in terms of exam and in terms of clinically to know is: one, it is arising from the endoderm. It arises from the region between the first and second pharyngeal pouches. The region from which it originates is called foramen cecum, from which a thyroglossal duct forms and it migrates upwards. In the process of the migration, you can have multiple sites of arrest in its migration, which is the clinical correlate of your ectopic thyroids and your lingual thyroids. And a persistent thyroglossal duct can form a thyroglossal cyst, which classically moves with your deglutition. Thyroid gland is the first endocrine gland to start secretion. Secretion starts about 12th week. Looking at thyroid hormone, the physiology. First thing is, what are thyroid hormones? Thyroid hormones that we know are T3 and T4. T3 is your triiodothyronine and T4 is your tetraiodothyronine. They both act via thyroid receptors which are TR alpha and TR beta. The T4 has 4 iodines. When you deiodinate them in your peripheral tissues is when you get your T3. If instead of your 1 and 2, if it's your 3 deiodinase, you get your reverse T3, seen in stress states where the imbalance of this enzyme is changed and you get more of reverse T3. Now, important to remember that T4 is solely the product of a thyroid gland. Nearly 100% is produced by the thyroid gland, whereas T3 is primarily produced by the peripheral organs via deiodination of the T4. The same thing in a little bit more tabular column showing the characteristic properties of T3 and T4. If you look at it, the total hormone concentration is in gross value higher for T4, but that gross value is still much lower a fraction of what it is bound. That's the first thing to understand. The second thing is about the half-life. T4 having a half-life about 7 days and T3 having a half-life about 2 days. The same applies for pharmacological preparations of the same. And the like I previously mentioned, T4 is almost exclusively from your thyroid, whereas T3 is only 20% from thyroid. The remaining is from your peripheral deiodination. And when it comes to which is potent, T4 is almost like a pro-hormone, which is not really potent. So in terms of potency, it is only 30% as potent as T3 in causing the metabolic effects or the receptor binding. Okay. Now, quickly looking at the steps of synthesis and secretion. Again, just a quick revision of biochem. We would have all gone through it multiple times. So it all starts with thyroglobulin, which is synthesized and discharged into the lumen. After which there is an active iodine uptake, which then undergoes oxidation to form an active iodine molecule, which then comes into the lumen of the follicle, where this combines with thyroglobulin, with tyrosine to form mono and diiodotyronides. Now these mono and di combine in different permutation combination and form your T3 and your T4, which is then bound to your thyroglobulin colloid and then excreted out in a lysosome. This lysosome takes it till the capillary side and exocytoses it. Now, once it reaches the capillaries, how do they reach the tissues that it needs to act? Most important thing to remember are they are mostly carried by plasma proteins to which they are bound. The most important plasma proteins are albumin is probably the least important when it comes to thyroid. Thyroid binding globulin, transthyretin and albumin. Albumin is probably one of the least important things. TBG is the more important thing. One clinical significance of the same, I'm not putting down. It is important to remember this in conditions where your thyroid binding globulin levels or the capacity is affected. For example, pregnancy, nephrotic syndrome. You have altered TBG. Once it's done, the proteins modulate how it goes to which tissues. And one of the important transporters through which it is actually entering the cells by active transport is using MCT8. That is monocarboxylase 8 transporter.
So when the TBG goes down, that means the action of T3, T4 increases, or?
Yeah, the peripheral unbound form of T3, T4 will be high. So the interpretation should include the fact that TBG is altered. There are some few tests to actually find out if TBG is altered, but common states where you should keep in mind. Nowadays, we have formulated new cutoffs based on these. Next is how does thyroid hormone act at a receptor level. So we all know that thyroid hormone acts via nuclear receptors. That is the key to remember from this whole slide, even if nothing else is taken away. So what happens is they enter the cytoplasm, then they enter the nucleus. The moment T3 binds, the co-repressor is removed from the receptor. And co-activators are recruited, causing gene expression. So the region to which it binds is called thyroid hormone responsive elements in the promoter region. But the key to remember is it's a nuclear receptor. Functions. We could speak 1 hour on thyroid hormone function, which is why the picture is so vague. So the things that thyroid gland produces, T3, T4 and calcitonin, I'll not focus on calcitonin, but the clinical endpoints of the thyroid hormones that are circulated are seen in your cardiac function in terms of the rate, the contractility, in your digestion in terms of peristalsis and mobility, brain development and your nervous system, more in children and more in adults than in normal age group people, bone health, increased thyroid hormones will cause increased bone resorption, muscle contractions, and calcitonin is through parathyroid, so much speak. Now, the only difference here is there is no way that we can actually look at the clinical effects of thyroid, and we don't have a biomarker to say that this clinical effect is there, so the thyroid hormone is acting at this level. So we have a couple of clinical endpoints like your heart rate to guide treatment, but we do not have a biomarker at the effector level to actually say if our thyroid is working well or not, which is one of the problems with thyroid, which is why we depend upon thyroid specific assays so much. Now, how does this whole secretion and the regulation of this thyroid hormone secretion happens? That is, like we again know, through our hypothalamic pituitary axis, which is a classic example of an endocrine feedback loop. The thyroid axis is one of the most sensitive axes. So this is a quick picture again showing the general basis of a hypothalamic pituitary axis. So your hypothalamus is releasing TRH, which is your thyrotropin releasing hormone, which is stimulating your pituitary, which is releasing your TSH, which is stimulating your thyroid follicular cells to produce your T3 and T4. Now this T3 and T4 are through a negative feedback loop inhibiting both TSH and TRH at a higher level at TRH than TSH. Okay. On the right side of that picture, it shows a follicular cell. So a few key points to remember from that picture is that a follicular cell is polarized. It has got an apical side and a basal side. The initial steps we learned that the iodine is actively taken in. That active taking in of iodine happens through the channel that is mentioned there. That is your NIS. What is NIS? Sodium iodine symporter. Okay. And your TPO is on the apical segment. These are the two things I want you to remember from this picture. And among all the elements of this hypothalamic pituitary axis, the master regulator is TSH, because TSH establishes the whole set point for this feedback loop. A couple lines on what is TSH. TSH is a 31 kilodalton hormone from the thyrotrope cells, anterior pituitary. Most of the anterior pituitary hormones have a pulsatile secretion. But thyroid stimulating hormone levels are not really affected by this pulsatile secretion because it relatively has a long plasma half-life, roughly 15 minutes, compared to the other stimulating hormones that are released. Which is why in clinical practice, it does not really matter at what time of the day you check your thyroid. Unless a minute difference in TSH is going to make a change in your diagnosis or treatment. Because even though it is pulsatile, even though you see the same peaks and nadirs, it usually doesn't affect in your clinical assays, nor in the levels because it's got a large plasma. Now, what are the regulators of TSH? Positive regulator, which is the most important one, is TRH, and that is via your T3 and T4. Please remember IGF-1 is also a positive regulator. Negative regulators, that is things that can suppress your TSH, not usually at the physiological levels, but at pharmacological doses. Definitely dopamine, glucocorticoids, and somatostatin. Something else that is clinically important to know about the physiology of TSH is that it belongs to a group of hormones that are called as glycoprotein hormones, who have a alpha subunit and a beta subunit. The alpha subunit is generally common and the beta subunit is distinct. So which are these three or four hormones which fall in the same category whose alpha subunits is similar? Yeah, TSH, LH, FSH, and your HCG. Why is this important to know? Yeah. So higher levels of other hormones can actually activate your thyroid receptors through the alpha subunit. The contrary can also happen. Your lactotroph cells become more sensitive to LH and FSH if you have a hypothyroidism, which is why asking the history for a galactorrhea is very important in patients with hypothyroidism, even if it's not a central hypothyroidism. Their prolactin levels will be high, and up to levels of 60, guidelines say that treat hypothyroidism, and they don't require any pituitary drugs for it. That's the importance to know that of the subunit and the fact that it's a glycoprotein hormone. Okay. The next is, how does TSH receptor act? So thyroid hormone receptors are nuclear receptors, whereas TSH receptors are transmembrane. So tell me some transmembrane receptors we know of. So that's the answer. That's the most common answer. So when you don't know the answer, that's the answer. So TSH receptors are G protein coupled receptors, which are coupled to GS alpha. They activate your adenyl cyclase, increase your cyclic AMP. And that's how a TSH receptor acts. Now, clinical evaluation of thyroid diseases. Since thyroid is a hormone that has systemic effects, clinical examination of thyroid disease is essentially a complete systemic examination. But what I am trying to look here through this process is things that are a little specific to thyroid. Most importantly, something that we generally don't do in our OPDs. Clinical examination of the thyroid gland. Very important in any patient suspected of a thyroid dysfunction. And there are a few key points that we need to keep in mind while examining the thyroid. Important things being neck-in extension. A neck-in extension can actually make a non-visualized thyromegaly visualized. One. The second key point is to remember that we need to be always palpating from behind, and we are looking to make sure that we can feel both the lobes, isthmus, any nodules within, and very important, in the neck extension position, are you able to feel the lower border of the swelling? If you can't feel the lower border of the swelling, that could indicate retrosternal extension of the thyroid, which can be clinically assessed by two methods. One, direct percussion over the manubrium sterni, where you can get a dullness. Second is by doing a Pemberton test. Now, how do you know that a mass palpated there is actually thyroid? Yeah, Mosul deglutition. And when you have a patient with symptoms and signs of thyrotoxicosis, always auscultate the thyroid for a bruise. Now, there is a WHO classification of thyromegaly or a goiter, which is grade 0, 1 and 2. Grade 0 is none, grade 1 is seen, grade 2 is neck swellings with some compressive features and an enlarged thyroid gland. A couple of other specific clinical findings to thyroid diseases. How are the ankle jerks in thyroid?
Delayed relaxation.
Yeah, delayed relaxation phase of your ankle jerk is classically seen in gross hypothyroidism. As told by my teachers, there was a time where they used to actually measure the relaxation phase, then use it to titrate their thyroid medicines. So, what is that sign actually called? It's called Voltman sign, where you get a classical delayed relaxation phase, best assessed by the patient standing with one knee bent on an elevated surface. That's how you actually check for a Voltman sign. Now, laboratory evaluation of thyroid disease, which is probably the core of what we are trying to discuss here, how to come up to a lab diagnosis of a thyroid disease. So we will look at thyroid function test, that is TSH, T3 and T4. So that is meant by functional assessment of thyroid. So in our practice, when we use the words euthyroid, hypothyroid, hyperthyroid, they are not based on the symptoms. They are based on the thyroid functional status assessment, which is the biochemical diagnosis. Okay. The second thing that you need is to see the morphology of the thyroid in cases that require the morphology to be played, where imaging comes into play. The third thing is, once you have your morphology and your functional status, you need to do an etiological workup to find out the cause of the thyroid dysfunction. That is where your thyroid specific antibodies and your uptake, iodine uptake scans come. So starting with thyroid function testing. The cornerstone of thyroid function testing is TSH. Why? Because it is cost effective, it is extremely accurate, and it is one of the best screening methods that we have. But if we are in a tertiary quaternary setup where free thyroid T4 concentrations are so easily available, do we still need to depend on TSH? Is TSH still better than free thyroxine concentrations? Yes. So TSH is more sensitive to change. So small changes in thyroid function can cause a logarithmic amplification in your TSH secretion. That's what's seen on the picture here. This is your T4 and this is your FTC. So for a small change in TSH, you see a larger change in, for a small change in your thyroid hormone, you see a larger change in your TSH, which is easily picked, which is why it is more sensitive. Okay, which is why TSH is actually a better screening tool than FT4, even if you have FT4 available with you. Now, a few points that we should remember about checking TSH is it's not a foolproof test because there is a big difficulty of defining reference ranges. What is normal TSH? Is something that is very difficult to define, varies between population, varies between labs, and varies between the assays that are used. Generally, for an adult population, we take a cutoff of 0.3 to 4.5, which is just the 95% confidence intervals of the distribution. Doesn't mean slightly low TSH or slightly high TSH is actually abnormal. They could just be healthy who fall beyond your 95% standard deviation. The next thing to remember is TSH varies with age. As your age goes up, your baseline TSH levels will go up. That has to be kept in mind while interpreting a TSH reports of an older patient. Correspondingly, the levothyroxine dose requirement reduces with age, since we're talking about age. Just keep that in mind that your patient's levothyroxine dosage requirements for the body decreases as the age goes up. That's the picture that is showing on the right is from a large study. Unfortunately, the slides are not clear enough for you guys to see that, but the first one on the left is your TSH going up, and the bottom one is your FT4 correspondingly coming down. One is in males and one is in females. But in both genders, it does happen the same way. The next thing to remember is for an individual, the reference range of TSH is always narrower than this 0.3 to 4.5. 0.3 to 4.5 is for a general population, but nobody's normal thyroid TSH value will fluctuate between that height. So their levels are much closer. So when you suddenly get a discordant value, when you measure, you should always check adherence. You should always check drugs that affect, because that is not normal physiology. Okay. So an individual's range is narrower than the standard reference range. Now after TSH, we can measure the thyroid hormones. What are the different methods that have been used to measure thyroid hormones? People do check total T3, total T4. Both are inactive and both are unreliable. Total T4 probably has a small role in Euthyroid 6 syndrome. But other than that, it really doesn't have a role in evaluating a thyroid disease. The next is free T3 and free T4 concentrations. They are very active. They are very reliable. And the most accurate method of measuring the amount of free T3, T4 is called equilibrium dialysis. Now there are two other entities which is brought into place just because of states that have altered binding protein levels. So that is called as a free thyroxine index. That is your free T3-4 levels corrected to the altered protein binding, which is calculated by a different parameter called as T3 uptake. So T3 uptake is otherwise called as thyroid hormone binding ratio. It is usually done by a resin trapping of the unbound radiolabeled T3. And common conditions where you see is pregnancy, nephrotic syndrome. This is a measurement that is usually done in a research level and not in a clinical practice level. These are the studies through which you've actually come with your new cutoffs for pregnancy and things like that. Not used in routine clinical practice. But when you have a patient with nephrotic syndrome and things and pregnancy, you should remember that my cutoffs are not the same. My interpretation is not the same. Okay, now how do we put this thing together? In a simple way, this is how we would put. The first thing that we're going to do for everybody is TSH. TSH can be high, normal, or low. Once you have your TSH, then you check your free T4 concentrations. If you have a TSH that is high and a free T4 that is low, it is hypothyroidism. If you have a high TSH and a normal free thyroxine concentration, then it is a subclinical hypothyroidism. What is subclinical about subclinical hypothyroidism? Nothing. Subclinical hypothyroidism, the term is a misnomer. It is a pure biochemical diagnosis. Patient can have symptoms. Patients need not have symptoms. But the word clinical there is actually a misnomer. It's a pure biochemical diagnosis. Please remember that again and again. Next, when it is low, we are thinking of hyperthyroidism. And when your FT4 is high, then it becomes hyperthyroidism. And when your FT4 is normal, in the same way we call subclinical hypothyroidism, we call it subclinical hyperthyroidism. Again, a pure biochemical diagnosis. Taking it slightly higher. This is what we would see in actual practice. Because we don't really get these algorithms, patients who fit into these boxes always. But if we try to put them in 6 boxes of high, low, normal of TSH and FT4, this is how it would come. So if you have a, if you have a high TSH and a low FTC, it is very clearly primary hypothyroidism. If you have a low TSH and a low T4, then the cause is secondary or a central hypothyroidism. But remember that a gradient between these two conditions can be seen in 2 states. One is Euthyroid 6 state and 2 is thyroid in transition. Thyroid in transition is just a new terminology they are bringing up for patients who are evolving from subclinicals to clinicals. Okay. But if you have a normal TSH and a low FTC, what are your possibilities? If the patient is critically ill, then you think of a Euthyroid 6 syndrome. If not, you think that this patient is probably thyroid in transition. We don't know which way they will transition. That's why it's called thyroid in transition. Okay. Now, for the same thing, TSH being high with the free FTC being normal, subclinical hypothyroidism. This is easy. Central is easy. Overt hypothyroidism is easy to understand. Please remember, Euthyroid sick and thyroid in transition can come with both extremes of TSH and both extremes of T4. Now, this is something that we need to see. This probably is something new. When we have a patient with high TSH and a high T4, similar to the central hypothyroidism, what do we think of? Not always. Not always. So when you have a high TSH with a high T4, it can be, what are the 4? Obviously, all of these things can be euthyroid and transition. I'm not talking about. But 2 things that can happen is, yes, one is a pituitary adenoma, which secretes TSH. But remember that if you have a thyroid hormone resistance syndrome, this will come exactly in the same way with a very high TSH and a very high FT4. Okay. Did this slide make sense? This is probably the most important slide. Now remember that when patients are on multiple drugs.
I don't understand why TSH should be high in thyroid hormone resistance.
We will come. We'll come. This is a slide on that. Why is TSH high? What is the whole class? So anytime in endocrinology you talk about a hormone resistance, the level up will be higher in your axis. Okay, that slide will come. When you check thyroid function, remember that your patients, when they are on these drugs, remember that these drugs can alter the thyroid function interpretation. Common drugs are amiodarone, heparin, phenytoin, and carbamazepine. The famous drug is biotin. That's why it's in red. That's what's commonly asked in exams. It interferes with your assay. Once you have your thyroid function test, all the patients with thyroid dysfunction don't need imaging, especially from a medical perspective. So in a medical perspective, after my thyroid function testing, if I find a thyroid dysfunction, I would proceed with my thyroid specific antibodies. So what are your thyroid specific antibodies? Thyroid receptor antibody, TSH receptor antibody 1, then anti-TPO and anti-thyroglobulin. Okay, these are the three more common thyroid specific autoantibodies. Thyroid peroxidase, TPO, is more commonly seen in Hashimoto's. Please remember that there is a small amount of overlap between all the three antibodies. So it's not that you can't get a TPO in a Graves' disease. So about 20% can have. Thyroglobulin is almost always seen in Hashimoto's. And thyroid receptor antibody, which earlier we thought was one antibody, we now know that it is at least 3 phenotypes of antibodies, which can either be a stimulating antibody, which is what we classically learn in Graves, where this antibody stimulates your receptor. But at the same time, right now we do know that there are neutral antibodies who do not stimulate, who do not block, and there are also TSH receptor blocking antibodies, which is seen in a newer entity these days called as atrophic thyroiditis, which is a immune thyroiditis. So the antibody that you see there is TSH receptor blocking antibody. Am I making sense?
Neutral antibody. If it doesn't block or stimulate, then
But on biochemical studies, they have found 3 forms. One which significantly stimulates, one which significantly blocks, and one with not major effect. So they've called it neutral. It doesn't really have a clinical significance yet. Yet is the word to use, because we did not know that there were 2 types before for TSH receptor antibody. And this picture is just to show how they overlap. There's a considerable amount of overlap, which is why thyroid function testing, thyroid specific antibody, and looking for disease specific clinical features are very important in reaching your final diagnosis. It cannot be an antibody alone based diagnosis because there's a considerable overlap. Looking into once I have done my thyroid specific antibodies, if my patient has a palpable nodule, is when I consider doing an ultrasound for the patient. So thyroid ultrasound is one of the most valuable tools for diagnosis and evaluation for patients with nodular thyroid disease. And it is usually used to differentiate between benign and malignant diseases. And thyroid neoplasms are an entirely different topic we will not go into today. But it is good to know how they evaluate these patients using a thyroid ultrasound, because when in our OPD, a patient who comes with a thyroid nodule has an ultrasound thyroid done, and the radiologist has classified that lesion using ThyRads, and the patient asks you, what should I do next? The answer is very simple. The answer is is this clear? Okay, I expected the projector to be bigger. Sorry for slightly smaller slides. So thyroid ultrasound, what they look is 5 factors: composition, echogenicity, shape, margin, and the echogenic foci. And based on the points, they call it TR1, 2, 3, 4, 5. 1 and 2, nothing to worry. 3, anything more than 2.5, FNA. 4, anything more than 1.5 centimeter in size, FNA. 5, anything more than 1 centimeter in size, FNA. It's as simple as that. Please do not tell them that your endocrine surgeon will tell you what to do. And when it is not required, you can tell the patient that this does not look suspicious and we will follow it up. Okay, so it's called ThyRads. Important thing. Diagnostic thyroid ultrasound imaging should definitely include central and lateral cervical node assessment as part of thyroid ultrasonography in all patients, which is why we do thyroid and neck. Now, once your morphology is done, etiological differentiations, especially in somebody who is hyperthyroid, depends primarily on your ability of the cells to take up the thing and light up. So that is called activity. So what happens is a radioactive particle which is attached to iodine enters the thyroid cell. Either the cell will glow with radioactivity or that cell will die. Invariably, all these cells will die. Now, what are the two common agents used? Is iodine 123 and iodine 131. 131 is what we commonly use because it is cheaper, it is more readily available, and it has a longer half-life. But it does have a small limitation that it can have something called a stunning effect because it captures a lot of high energy that the whole thyroid can suddenly look bright, where it is actually not bright. But with that differentiation, which is why you can always do a technetium scan after that to differentiate hot and cold. But even with these disadvantages, we still use iodine 131 because iodine 123 is extremely costly. Quickly looking at some pictures of radioactive iodine uptake study in patients with thyrotoxicosis. The picture on the left here is actually showing a cold nodule. You can see a diffuse uptake all around the thyroid with one specific area of no uptake. That's called a cold nodule. Why is cold nodule important? Not from a physician's perspective, but yes, cold nodules are almost always malignant. So it looks cold here, but it is sinister. The next common thing that we see is a Graves' disease patient, where again you can see that the tracer has been uniformly taken up by the entire thyroid lobe, including your pyramidal lobe, with high uptake. Okay, that is classical of Graves' disease. We'll go into that again, just quickly show you. This is a toxic multinodular where you see patchy uptake and you see hot and cold nodules. Some nodules are taking up, some nodules are not taking up. This is a toxic multinodular goiter. This is called as a hot nodule, where you have a baseline patchy uptake with one single nodule taking up all the uptake, but the remaining thyroid is still getting some uptake. This is called autonomous nodule or a toxic adenoma, where you get the nodule that is active and toxic uptake with complete uptake, high uptake, where the remaining thyroid is not visualized, means no tracer uptake. Why might that be happening? The word is, which is why autonomous nodule is a better word than toxic adenoma. So that autonomous nodule is independent of TSH for its activity, whereas the normal thyroid is dependent on the TSH for its activity. The autonomous nodule, irrespective of the role of TSH, is going to produce a lot of T4s and T3s, which invariably through feedback loop will suppress your TSH, and that suppressed TSH is what is required for the remaining thyroid to take up, that they are not able to, which is why it's called as autonomous nodule. Okay, so the normal thyroid is TSH dependent. The autonomous nodule producing free thyroid hormones cause feedback inhibition of TSH, hence taking away the stimulant for the thyroid follicular cells in the normal thyroid gland. And in a patient with hyperthyroidism, when you have a very patchy to low uptake, it is usually a thyroiditis. Now, how do you approach hypothyroidism? Hopefully, we go through a few cases to quickly see how do we approach this problem in OPD or in our wards. I will not go into the theoretical details of each cause of hypothyroidism. Then we will not finish this today. Okay. So quickly looking at the causes of hypothyroidism, because we should know what we are looking for, what we are evaluating. Your causes can be primary, secondary, or transient. So the primary causes are congenital, usually we don't see. Autoimmune, most common cause. Remember, autoimmune is not just Hashimoto's. After this session, autoimmune thyroiditis should include atrophic thyroiditis also. Iodine deficiency is the most common cause in areas which are not iodine sufficient. A few drugs that can cause hypothyroidism, very important in current day and age. Common things that we think are iodine, amiodarone and lithium. But what we actually see more and more is anti-cancer drugs causing hypothyroidism. Tyrosine kinase inhibitors and immunotherapy drugs. Also, you can have a direct infiltration of your thyroid with any of your infiltrative diseases like your amyloid, sarcoid, much lower causes. 60 to 80% of all hypothyroidism are autoimmune hypothyroidism. Now, coming into secondary causes. By secondary causes, we are thinking causes that are above the thyroid. Yeah, pituitary or your hypothalamus. Any disease affecting your pituitary or hypothalamus. It's just a list of all the diseases that affect your pituitary or your hypothalamus. Now, you can have some transient causes of thyroid, hypothyroidism. Example, one is, most common is subacute thyroiditis. We will speak about subacute thyroiditis in some time. The other is other silent thyroiditis, which is something like postpartum thyroiditis. And any critical illness can cause transient hypothyroidism. That is your Euthyroid 6. So let's go into a few cases. Let's have one so that there is no group answering. If the first years can volunteer to read the question, whoever is volunteering can go through that question. Who are the first years here? Akash, case 1. Sorry, few names I know. 37-year-old female, lethargy, fatigue, irregular menses, coarse facial features on examination, has a WHO grade 1 goiter on examination. The normal values are given in bracket just for reference. The lab values are TSH is 23, free T4 is 0.62, anti-TPO is 628 and anti-thyroglobulin is 210. What is her thyroid functional status? What are the questions I would want you to think and answer? Second is, this is how you should think of in an OPD when the patient comes. Does she need a thyroid ultrasound? What is her etiological diagnosis? And how will you treat her? What is her functional thyroid status, Akash? You have an elevated TSH with a low free T4. So the thyroid functional status is hypothyroidism. Does she need a thyroid ultrasound? No. There is no palpable nodule. At first step of evaluation, she does not need thyroid ultrasound, which is why we have done our antibodies. So it becomes even more clear that you don't need. No. With all these pictures, what do you think her etiological diagnosis is? Yeah, autoimmune hypothyroidism, probable Hashimoto thyroiditis. How will you treat her? Thyroid supplementation is an MBBS level answer. Of levothyroxine, leothyronine, natural extracts containing both levothyronine and tetrahydrothyronine. So it's oral levothyroxine at a dose of 1 to 1.6. 1.6 is your replacement dose. Everybody might not require a replacement dose. And how long will you give it? Till the patient becomes euthyroid. Is it? John, how long will you give oral levothyroxine for a patient with a diagnosed Hashimoto thyroiditis with hypothyroidism, with primary hypothyroidism? Lifelong. Okay. So oral levothyroxine at 1 to 1.6 micrograms per kilograms per day, lifelong, and you titrate to target the normal TSH. Now, quickly into autoimmune hypothyroidism, more common in females. It's quite common. 4 in 1,000 is a prevalent disease. two forms that we know that it exists right now. One is Hashimoto's thyroiditis and the other is called atrophic thyroiditis. Hashimoto thyroiditis is associated with goiter, whereas atrophic thyroiditis is associated with an absent residual thyroid tissue. The pathological hallmark of Hashimoto thyroiditis is lymphocytic infiltration and minimal fibrosis. Whereas in atrophic thyroiditis, it is extensive fibrosis with near absence of your thyroid follicles. The genetic risk factors are HLA-DR3, 4, 5 polymorphisms, which is why it is more associated with other autoimmune polyglandular syndromes with type 1 diabetes, Addison's, pernicious. The key effector cell is CD8 plus cytotoxic T cell. The antibody mediating the disease is anti-TPO or anti-thyroglobulin in 80% of the patients. The 20% can still have a thyroid receptor blocking antibody. And in atrophic thyroiditis, you usually get an anti-thyroid receptor blocking antibody. Now, atrophic thyroiditis, people say there is a different thoughts on it. Some people say that it is just a Hashimoto's, which is very, very advanced. But finding that antibody has changed how we look at it. 1. 2, a specific disease where it is described is IgG4 related disease. Okay, atrophic thyroiditis is described in IgG4 related disease. Okay, it's there in the 21st Harrison and not the 20th. It's new. So, quickly looking at clinical features, common things, but fatigue, cold intolerance, weight gain, constipation, dry skin, menstrual irregularities. On examination, the key things that we're looking for is a goiter, because usually Hashimoto's will have a small goiter, small diffuse goiter. They'll have bradycardia, they'll have diastolic hypertension, they can have their Voltman sign. Up to 30% of overt hypothyroid patients can have pericardial effusion, not clinical, but on echocardiography. And something that is very commonly that I have noticed in our OPDs is patients presenting with entrapment neuropathies. Are quite a large number of females who come and tell us with symptoms of median neuropathy end up having hypothyroidism. So if they do not have diabetes, it's worthwhile discussing with the patient the benefits of checking a TSH. It's not an indication for TSH screening, but it's worthwhile discussing with the patient on the benefits of a thyroid screening in them. Now, it is also associated with a lot of other metabolic abnormalities, which we should look out for. One is hyperlipidemia. 2 is a macrocytic anemia. 3 is more commonly hyponatremia. Very rarely it can cause elevated CPK also. What kind of hyponatremia do you see in hypothyroidism? Can one of the first years answer? Somebody else, please. Tell me, what do you get? You get euvolemic. Do you get SAADH? Do not call a euvolemic hyponatremia SAADH unless euthyroid, normal cortisol, normal renal function. Never forget these 3 things. Okay. Sure. So you get a euvolemic hyponatremia. That's true, which is not SAADH. Okay. Now, how do we manage them? A few key points alone. One is regarding TPO testing. Do everybody need TPO testing? So as per recommendations, they say that if feasible, consider TPO testing for everyone who you suspect. But in our resource limited, I couldn't find an Indian guideline per se that says should you check or not. But explain the cost to the patient, consider testing it for everybody. Because it's got prognostic value over long term. It tells you how faster you should control your thyroid and things like that. 1. 2, there was an olden concept of repeating the TPO levels to see how well we have treated the disease. Never repeat TPO. That line is from the American Thyroid Association. Never repeat TPO testing. Okay, that is regarding the testing. Now regarding treatment, everybody needs thyroxine. That's very clear. Remember the problems of thyroxine and the patients in which these problems can be accelerated. In such patients, go slow. That is the concept. But as far as your guidelines are concerned, anybody who is less than 65 and doesn't have a cardiovascular disease, the Western guidelines say start at 1.6 directly, rounded to the nearest 25. Most clinical expert reviews from Indian subcontinent or Asian subcontinent say start at 1 and then up titrate. But if you have an adult who is more than 65 years or anybody with the history of a cardiovascular disease, you always start slow. So there the recommendation is to start at 25 to 50 micrograms per day with up titration every 6 weeks until you reach stable TSH levels. Am I clear? You guys can stop me anytime you want. Now, something that we should always ensure in OPD, when we see hypothyroid patients who are taking levothyroxine, are three things that I would like to call as compliance, spacing, and timing. I say CST. In my charts, if you see CST. So that is compliance. So this is a very important thing for thyroid hormones to work. So compliance, the patient should take the medicine every day. Timing, it has to be taken on a empty stomach, preferably in the morning. Third thing is spacing, 45 minutes to 60 minutes of gap between any other meal that is going in for adequate absorption of the drug. These are all small reasons why we go up on the doses of patients with levothyroxine when you don't ask for spacing. So when you clearly ask the interval between the drink that they have and the coffee that they have and the 15 minutes. But if you don't ask it specifically, they'll say they're taking it empty stomach. So in such case, if there is not much of a lab abnormalities, we can actually tell the patient to do the spacing and come back. And the levels can actually go up. So it's very important to ask compliance, spacing, and timing. These are just my words. This is not from any guideline, but please make sure that compliance, spacing, and timing are checked. It's put such that I remember a CST. So when you CST a hypothyroid patient should have done all these three. Only then you should CST. Otherwise, no CST. Next, how do we follow up or monitor these patients? How often do you want to check your TSH? So we all believed 6 weeks, classical teaching. But all the current recommendations say that you need to only check TSH 3 monthly until you get 2 stable TSH values. After which you need to check annually. Okay, you did I feel we sometimes overdo thyroid testing. Now, once you give levothyroxine in an appropriate weight-based dose, you have ensured that your patient is compliant, is spacing, at least from what they can tell us, but still is symptomatic, is one of the few indications in hypothyroidism where you would check an FT4 levels to actually assess the adherence to therapy. Otherwise, free T4 concentrations are never repeated in a hypothyroidism patient. You never treat to target normal FT4. You treat to target normal TSH. Very important. This is from the NICE guidelines 2019. Very simple way of putting the guidelines and not making it complicated. Case 2. Somebody. So here, who's worked in oncology before here? Bond something? No? For you. Very easy. 54, male smoker, metastatic adenocarcinoma lung, stage 4A, high PDL1, finished his main initial chemotherapy, and right now he is on a maintenance nivolumab. Nivolumab is an immune checkpoint inhibitor, which is used as an immunotherapy, the drugs we said before. And important to remember that at onset of therapy, he was biochemically euthyroid. And he's come to you with an excessive fatigue and insomnia. On examination, no palpable thyroid. TSH is grossly elevated, 108. FT4 is reduced, 0.57. And thyroid antibodies are slightly elevated. First question, like we would go through the same process in most cases. So, what is his thyroid functional status? Hypothyroid. Does he need a thyroid ultrasound? No. What is his etiological diagnosis? Why do we say drug induced? Because he's taking a drug that is predisposing him to hypothyroidism. He was biochemically euthyroid prior to onset, and we know that this drug is known to cause production of anti-TPO. Okay, so that we can, I'm not going to put a slide on this, but please remember that the diagnosis here is autoimmune hypothyroidism, probable immune checkpoint inhibition induced hypothyroidism. Very common. Very common. Very common to an extent that if somebody is not developing hypothyroidism on immunotherapy, we doubt their compliance. How do you treat? With similar oral levothyroxine 1 to 1.5. Okay, next, John. So here we have a 43-year-old lady who's a diabetic hypertensive who's currently admitted in the ICU with COVID-19, ARDS, associated severe pancreatitis, and on a mechanical ventilator. The ICU consult is for a thyroid dysfunction. And the dysfunction is this. TSH is 0.2, free T4 is 0.75. And in this case, since this might play a role, I have also checked a total T4, which is 2.5. So her thyroid functional status is? It's very difficult to say. There is no clear way to say what actual functional status of that patient is. That's why I've written query euthyroid. You cannot say because biochemically this patient is hypothyroid. Now, which test can actually tell us if this is actually a thyroid primary hypothyroidism or a central hypothyroidism? Because your TSH is low and your FT4 is low, it could be central hypothyroidism. How do we know that this is not central hypothyroidism but sick euthyroid? Reverse T3, very good. Like we said in stress states, the balance of the deiodinase enzymes shift from 3 to 1, 2. So then you get more reverse T3. Okay, sure. How do we treat her? Yeah, treat the underlying critical illness. Very, very important to repeat a thyroid function test at 6 weeks. So quickly, briefly about sick euthyroid syndrome. What happens in a hypercatabolic stage? You have a slightly low T3. There is a lot more of peripheral conversion of T4 to T3, which is what is making your FT4 to look low. But your total T4s can still be within the range. And you can get a very high reverse T3. Along with this peripheral conversion, a lot of them become reverse T3. Is it quite common? Yes. In a hospitalized patient, it is extremely prevalent. And it can come in all 4 forms. A classical euthyroid 6 syndrome, or they can have an isolated reduced T3 or an isolated reduced T4 or an abnormal TSH. All 4 patterns are common. Most common is sick euthyroid syndrome. And if you look at this graph was put here. When you get the presentation, please go through it carefully. But the graph is put here to know that depending on the stage of severity of your illness and your stage of your recovery, euthyroid 6 syndrome can actually present with all possible abnormalities in your thyroid dysfunction. You can have a high TSH, low TSH. You can have a high FT3, low FT3. You can have a high FT4, you can have a low FT4. Okay. Which is why generally, unless you strongly suspect thyroid dysfunction to be the primary cause of this critical illness, do not test for thyroid in a critically ill patient. What is this? Oh yeah, this is just to say that reverse T3, how it happens, and reverse T3 is what is used for confirmation, never used in clinical practice. In clinical practice, what is the most important thing is my patient in stressful state or not? If my patient is in a stressful state due to some other reason, my interpretation of my thyroid hormones can never be correct. Unless I think this critical illness is because of my thyroid dysfunction. For example, a Graves' disease patient who comes in thyroid storm with acute decompensated heart failure, intubated in ICU, it is quite difficult to say if he is actually having euthyroid 6 syndrome versus Graves' disease and thyroid storm. There you will do, because you suspect that the Primary problem could be that. In all other cases, avoid testing thyroid. The same applies to all the patients you are admitting for pneumonias, pyelonephritis, heart failure, COPD exacerbation, all the common admissions we get. If not strongly suspecting a thyroid disease, kindly avoid thyroid testing when they are in patients. That's just a waste of 2,000 rupees for the patient. Because a subnormal or a slightly elevated TSH will promote the physician to send the remaining panel. It's just an added cost with zero benefit to the patient. Very, very common. Very, very, very common in hospitalized patients. So a few key points from Dr. Felix in Endo about Euthyroid 6 syndrome will be what I just said. Very, very important. Avoid testing unless strongly suspected. TSH can even be less than 0.1 in Euthyroid 6 syndrome. Hence, very difficult to differentiate from a Graves. So the clinical suspicion and the suspicion of is that dysfunction causing the disease extremely important. Pre-illness thyroid function test, if available, is extremely valuable. And mandatory follow-up testing after 6 weeks as per recommendations. And the other table is again showing a tabular column of that same picture before that. You can have all extremes of thyroid dysfunction in terms of TSH, T3, T4 based on the severity and at what phase of your illness you are. Case 4. I only know you guys. Nobody else is coming. Sorry. So 51-year-old male. Unless you actively participate, some of these things might look very easy, but it might disappear from your heads. Volatile information. 51-year-old male, mild generalized fatigue. Just come for a general checkup to you actually. Examination was quite normal. TSH is 7.6. FT4 is 1.2. Anti-thyroid peroxidase is 180. So let's go through the same questions. Okay, sorry, it's his. What's his thyroid functional status, etiological diagnosis? How will you treat him? Sorry, okay. Yeah, you already know the diagnosis. So here, the biochemical diagnosis is subclinical hypothyroidism. Why? No, let's not have combined answers. Don't devoid a postgraduate the opportunity to learn by answering. Yeah. So you have an elevated TSH with a normal free thyroxine concentration, subclinical hypothyroidism. What is this etiological diagnosis? Evolving, probable evolving Hashimoto's. How will you treat him? How many of them think that we should start low dose levothyroxine? Nobody thinks we should start levothyroxine. Nobody is concerned about the TSH being more than 7.5. Very good. That's the previous guideline. 7.5 was an arbitrary cutoff in one of the previous guidelines, plus CVD minus CVD. Now it's not there anymore. So now the cutoffs are all 10. So it's quite easy to say. So here, I would approach this problem like this. A TSH less than 10. No significant symptoms, but positive TPO needs more closer follow-up. So annual thyroid function testing. When he becomes biochemically hypothyroid, I will start treatment. What are the indications for the therapy? Either they should have significant symptoms. Then you can consider low-dose levothyroxine. Mild generalized fatigue is not a significant symptom. Or if they are in biochemical hypothyroidism. So quickly going on to subclinical hypothyroidism is what we just described. Now elevated TSH, normal FTC, 10% of the adult population. Most common cause is a evolving Hashimoto's thyroiditis. Why is it important to even pick up subclinical hypothyroidism? We do not intend to treat them. So they are associated. It is very clearly shown that they are associated with a higher incidence of heart disease and osteoporotic bone disease. Not osteoporotic bone disease. Increased risk of heart failure, coronary artery disease, and atherosclerotic heart disease. Now, why do we think treating subclinical hypothyroidism is not beneficial? Two reasons. One, the only reason why we call him hypothyroidism is because he's got a elevated TSH. Remember the problems with measurement of TSH. His age is high. His reference range might be different, which is why his functional status is still normal. So then, what can give us a clue towards patients who will actually progress? Is one, presence of symptoms. It can happen even before your FTC actually drops down because TSH is more sensitive than FTC. Two, presence of a TPO antibody. Tells you that these are the patients who might actually progress on to requiring treatment. That's why they require more close follow-up. But there is no large trial that shows that normalizing TSH improves mortality in subclinical states. Okay. Okay. On general approaches to treatment, what is you see on the left is your NICE guidelines. Again, quite simpler to adopt in our practice. What you see on the right is your American Thyroid Association's recommendations on when to treat. They have a different cutoff with the different risk factors, but essentially the concept is summarized here. So, and this looks like a very practical way to approach patients in your OPD. So, if you have an adult, before we go on to treatment, anybody with subclinical hypothyroidism, unless they have significant symptoms, the diagnosis should be confirmed by repeating a thyroid function test after 3 months. And you should still have subclinical hypothyroidism. Okay. That is when you call it subclinical hypothyroidism, not as the first value. At the first value, there can be thyroid in transition, basically. So if you have an adult more than 60, less than 65, TSH more than 10, 3 months apart, I'm not repeating 3 months apart. In all conditions, it should be 3 months apart. What would you do? Normal FTC, TSH more than 10, adult less than 65. I would start treatment because his risk of osteoporosis, his risk of cardiovascular mortality, all that with my therapy is much, much less. And his TSH is more than 10. A pointer that adds to it is if TPO is positive. Now, if you have an adult who's less than 65, but his TSH is between 4.5 and 10, but he has very significant symptoms, he is still a candidate for a trial of oral levothyroxine therapy for 6 months. In 6 months, his TSH normalizes, but his symptoms don't get better. Please look for alternate cause. Stop thyroxine, look for alternate cause. Okay. And adults less than 65, TSH 4 to 10, no symptoms. Follow-up. Follow-up frequency will depend upon TPO positivity. TPO positive, you follow up annually. TPO is not positive, you follow up biannually. I'm sorry, that text is missing from here. Oh, yes, sorry. Annual testing if TPO positive, once in 2 years if your TPO is negative. So if you get a gentleman who is less than 65, TSH of about 7, like the previous case, always do TPO in younger patients. To know who are the patients you need to follow up faster, who are the patients who will evolve into an overt hypothyroidism. Now, those are the 4 or 5 common scenarios of hypothyroidism that you guys see. A couple scenarios that I have not put is one is central hypothyroidism. I have not made a case about that. That's something that you can get. Or a thyroiditis in its hypothyroid phase. Other 2 cases that we have not made any cases. Just remember it. Now, going on to hyperthyroidism. In a similar way how we looked at hypothyroidism, a few definitions are very important. What is thyrotoxicosis? It's the excess state of excess thyroid hormone causing clinical features. And what does hyperthyroidism mean? Thyroid hormone, thyroid gland function is high. Can one exist without the other? Yes. For example, most of your thyroiditis. The thyroid is not hyperfunctioning, but there is spillover of hormones to the circulation that your body is in a state of thyrotoxicosis. Am I making sense to all the first years? So when you have a thyroiditis condition or a similar to thyroiditis conditions, your thyroid gland is actually not hyperfunctioning. So you are not hyperthyroid. but there is spillover of the hormones to the circulation that make you thyrotoxic. So all hyperthyroidisms will have thyrotoxicosis. All thyrotoxic patients need not be hyperthyroid. So now looking at the similar causes of thyrotoxicosis is again primary hypothyroidism, hyperthyroidism, and the most common causes that we see are, from a physician's perspective, Graves, but more common than Graves, toxic MNG, multinodular goiter, a toxic adenoma. Sometimes you can have a functioning thyroid carcinoma metastasis, and iodine excess. Not at all common. Now, what are these conditions where you can get thyrotoxicosis without hyperthyroidism? Here I have not added with thyrotoxicosis because all of these patients will invariably have thyrotoxicosis. Okay. So thyrotoxicosis without hyperthyroidism, that is, body has a state of excess thyroid hormone in circulation, but thyroid gland is not hyperfunctioning. Examples will include here anything that destroys your thyroid gland. One. Or if you take levothyroxine from outside. This is the easy way to remember. So what are the things that destroy your thyroid? A subacute granulomatous infiltrative thyroiditis. Some drugs that again cause fibrosis within the thyroid. Amiodarone. Radiation, which again causes fibrosis within the thyroid, are the common causes for thyrotoxicosis without hyperthyroidism. So easy way to remember is destructive thyrotoxicosis and thyrotoxicosis factitia. Factitia is basically you take in a lot more of levothyroxine. Okay, and among the destructive, drugs, radiation, amiodarone, subacute. It's an easier way to remember it like that. And as usual, your secondary hyperthyroidism, which is causes above the thyroid, which will usually be a TSH secreting pituitary adenoma, a very important entity called gestational thyrotoxicosis. Why? Beta, yeah, the same concept of a 4 glycoprotein hormones having similar alpha subunit but different beta subunit. It's the same concept. When you have a very high HCG, it activates your taste. Now, clinical features a lot. Constitutional weight loss, hyperphagia, skin you get anicolysis, increased perspiration. Cardiovascular is more of tachycardia is the most common thing, but you do get atrial fibrillation. You can get congestive heart failures, irregular menstrual cycle, anxiety, agitation, psychosis, tremor. Any female patient with neuropsychiatric symptoms, kindly do a TSH screening if the family is affordable for the same. Because an easily correctable cause for a neurocognitive disturbance. Patients who come with anxiety and insomnia, always remember thyroid in your mind. Do not label it as GAD with depressive features or diseases like that. Please check thyroid. Unrelated, but since I have to convey that, please check iron levels. Iron deficient state is one of the most common causes for all these problems. Metabolic abnormalities are hypercalcemia, insulin resistance, and osteoporosis. Now, how do we approach? The approach is actually the ecological differentiation. We need to know if this is just, there is thyrotoxicosis, that is for sure. Now I need to know if is there hyperthyroidism or not. That is my thyroid gland over functioning or not? How can I do that? Earlier days we used to depend on iodine uptake scans. Nowadays the algorithm has moved a little towards non-invasive testing with lesser side effects. So as per all recommendations, the first thing you should do is a TSH receptor antibody. If that is negative, only then you really need to do a iodine uptake scan. But in our setting, we usually do both together. Now, in patients with thyrotoxicosis, who are these patients who need ultrasound? Only if they again have a palpable thyroid nodule. Okay. Now, diagnostic approach to a thyrotoxicosis. Let's look at this picture. It's much easier than that picture. These are the 4 common things that are done for thyrotoxicosis, of which let's eliminate the last column right away. The only condition where thyroglobulin levels have a role to play is factitious thyrotoxicosis, where it will be undetected. It will be undetectable. None of the other conditions thyroglobulin plays a role. So let's eliminate the last column with that. Now, the common conditions that we see, we have to do the antibodies uptake scan and plus minus ultrasound. Now, your first step is antibody. If your antibody is positive, you've already got your disease as Graves. But looking at the features of other imaging in Graves, yeah, uptake will show a high uptake and a diffuse uptake. So two things we need to say: is the uptake high or low? Is the uptake uniform, patchy, or focused? This is what we are trying to do. Two things. Now, if your antibody is negative, then we do a radioactive iodine uptake study. Like we quickly went through the previous RIU study pictures. If you have a normal or a high activity with patchy uptake, it's a toxic MNG. If you have a focal, unifocal uptake, but the remaining thyroid is suppressed, it's toxic adenoma or an autonomous nodule. Cases. Okay, first case. 40 male, 10 kg weight loss in 3 months, anxious, bilateral hand tremors, increased sweating, soft, small, diffuse thyromegaly. Labs are TSH is extremely suppressed, 0.005. Free T4 is 5.4. Total T4 is 30. Okay. So now my question is, what is this thyroid functional status? Hyperthyroid. What is the next step in evaluation? TSH receptor antibody. And if it's negative, radioactive. So that much we know. Now, in the same patient, TSH receptor antibodies come positive, more than 40. And the uptake is looking like this. Yeah, Graves. Diffuse, high uptake, including pyramidal lobe. Graves. So, first let's say, what is this? What is this uptake? It's a diffuse, high uptake, including pyramidal lobe. That's how you say that it is Graves. Next, what is the etiological diagnosis? Graves disease. How will you treat him? Beta blockers, that is propranolol, and antithyroid drugs for 12 to 18 months. Which is not the clear answer to the question. Correct. So we'll come to the clear answer. Quickly, looking at Graves disease. What happens in Graves disease? Yeah, so you have thyroid stimulating immunoglobulins, which are of many types. Most common one that we know is your TSH receptor stimulating antibody, stimulating your thyroid cells to actively secrete T4 and FT3, overriding your TSH feedback loop. This is essentially what is happening. This whole pathway has a cross linking with IGF-1. Important to remember, insulin related growth factor 1, which is the key pathogenic mechanism in orbitopathy or Graves ophthalmopathy. Clinical features. Clinical features are 4 cardinal things. One is Graves hyperthyroidism. That means you get an enlarged overactive thyroid with signs and symptoms of thyrotoxicosis. Always remember that there is a category of these patients who can come with masked thyrotoxicosis with weight loss and fatigue, especially elderly, frail gentlemen. And at that time, it is called apathetic thyrotoxicosis. Okay. Actually, have Graves. They'll not show that, they'll come and tell fatigue, weight, they will not look hyperthyroid, but it's masked thyrotoxicosis. They'll only come and say fatigue. The next cardinal thing in Graves disease is ophthalmopathy or orbitopathy, which are ocular abnormalities other than lid retraction. Please do not say lid retraction as a sign of Graves or orbitopathy. Lid retraction is a sign of hyperthyroidism due to any cause. Now, what are the characteristics of Graves or orbitopathy then? One is all the extraocular muscles are characteristically enlarged, which you can see if you do a CT imaging. Second is The earliest sensation that patient says is a gritty sensation. Next is common things. Common things are proptosis, periorbital edema, chemosis. And the most dangerous of all the clinical effects of Graves' orbitopathy is optic nerve compression at various levels, either at the apex or the orbit. And you can have papilledema field effects. So Graves' hyperthyroidism, Graves' orbitopathy, usually seen in roughly 30% of patients. Then you have pretibial myxedema, which is a localized dermopathy. That is Graves' dermopathy or thyroid dermopathy, seen only in less than 5% of patients. Most common site is your anterior tibia, shin. That's why it's called pretibial myxedema. And how does a typical lesion look? Indurated plaque with a orange skin appearance. This is how a typical lesion would look. Your body orange appearance, basically. And extremely specific, but extremely rarely seen is thyroid acropathy, which is a grade 3 to 4 clubbing seen exclusively in Graves' disease because of Graves' disease. Seen only in less than 1% of patients. But if it's there, it tells you that it is Graves' disease. Very, very specific. Now, so this is the picture showing orbitopathy, pretibial myxedema, and the thyroid acropathy. There are multiple scoring systems to say how severe the ophthalmopathy is. Something that is very simple to remember, not the most effective, is no specs. That is no sign, only sign, soft tissue proptosis, EOM involvement, corneal involvement, and vision loss in progressive nature. There are many other scoring systems for thyroid orbitopathy. Management, quickly looking into it. What are the cornerstones of managing a Graves' disease patient? One is obviously symptomatic treatment, that is your beta blockers. What do? No, first they block the peripheral action, that is blocking the beta receptors. Then they also, not all, only propranolol. What are the drugs that can be used as beta blockers in Graves' disease for symptom control? Propranolol, metoprolol. So in a cardiac patient, you can use metoprolol. But will metoprolol block conversion of thyroxine to peripheral thyroid? No. Now, what are the few remarks about use of beta blockers? One, it does not influence the course of the disease. It is only a symptomatic treatment. And like I said, you can use cardioselective beta blockers in patients with other reasons to not give propranolol. Now, that is for symptomatic. The definitive therapy, we have three options. We have antithyroid drugs, we have radioactive iodine, and we have removal of the thyroid gland. So antithyroid drugs commonly used are methimazole, carbimazole, and PTU. PTU is generally preferred either in first trimester of pregnancy or in thyroid storm. Otherwise, in most clinical conditions, we prefer carbimazole, is what we generally use. Okay. It is usually given as a single dose and usually given at a higher dose and then titrated down and not lower dose to titrating up. What are the problems with giving patients only antithyroid drugs? Very high recurrence rates. For example, if you give this patient 18 months of antithyroid drugs and stop it, the chance of recurrence is extremely high. This is the problem with treating somebody or a Graves only with antithyroid drugs. The two other options we have are radioactive iodine and thyroidectomy. Pros and cons, one is outpatient procedure, the other is an inpatient operative procedure. One is cheaper, iodine is cheaper, whereas the surgery is going to be more costlier. But recurrence rates are slightly higher in iodine than in surgery. Obviously, we are removing it out. But very, very important thing to remember are the last special circumstances in both of those things. Iodine ablation should not be used for patients with active ophthalmopathy or pregnancy. Do not give radioactive iodine. Oh, there's one more. Quickly looking at again the same thing, the drugs and how it works. And this group of drugs that are antithyroid drugs are called as thionamides, which can inhibit peroxidase. It can also, some of them can also inhibit your peripheral conversion. The key differences between PTU and methimazole. To remember is PTU is generally used in first trimester of pregnancy, thyroid storm. Most other conditions, carbimazole, methimazole is preferred. Key takeaways, this is what I just said. But effectively what I want you to understand is most patients we start on antithyroid drugs. But what happens after 18 months or 1 year to 18 months? You need to give them a definitive therapy. Do not forget that. And that definitive therapy can be ablation versus thyroidectomy depending on multiple factors. One, if you want to do ablation, you need to have no orbitopathy, like I said before. Patient should not be pregnant. Patient should not have any significant nodules, and it should be a small volume so that low dose can ablate the whole thyroid. Any of the other features, we would prefer thyroidectomy. But the definitive treatment is not antithyroid drugs in view of very high recurrence rates once you stop the drug. So this is a slide that shows how to treat Graves' ophthalmopathy. I am not going to dwell into how to treat Graves' ophthalmopathy, but there's an interesting drug here that I want to highlight. So what is the key pathogenic mechanism in Graves' orbitopathy? Is related via IGF-1 receptor. IGF-1 receptor. So people are trying to target, because Graves' disease is immunologically mediated, so they've been trying B cell depletion with Ritux. Not really been successful. But a drug that was approved a couple years ago. So this is the first drug that is shown to have benefit in Graves' orbitopathy. It blocks the monoclonal antibody against your IGF-1 receptor. The name of the drug is teprotumumab, for all the entrance boys. But it's a drug that is approved 2 years back. It's the only drug so far that is approved for thyroid orbitopathy. And the drug name should make us remember that IGF-1 receptor plays a huge role in thyroid orbitopathy. Because if you look at it, the muscles become bigger. It's all growth that's happening there, which causes congestion. Okay. The slide is only for highlighting that drug. Okay. Now, okay, before case 6, this patient, the boy we discussed, has Graves' disease. I start him on carbimazole. And I follow his FT4 and it's coming down. He's on treatment. He's calling me, telling me I'm having fever for the last 3 days. So what should you do? You should tell the patient to check. Should you stop your carbimazole? So options can be, don't do anything. 2, continue the same thing that what you are doing. 3, stop methimazole. 4, do a CBC, withhold methimazole or carbimazole till your results come. The answer is the last one. So you have to do a CBC, you have to withhold your carbimazole till your results come, and you have to rule out a agranulocytosis. Yeah. Just want to highlight the side effect of carbimazole. Very common. So once they have a viral infection, you should be a little careful. Now, going on to the next case. 37, female, 10 kg, same. Okay, I forgot to say. It's the same. Instead of the male patient, it's a female patient, with the differences being she has a nodular WHO grade 2 goiter and her ultrasound is showing multinodular goiter. That's the only 2 differences. Because she had a goiter, nodular goiter, I did a thyroid ultrasound, which is showing multinodular goiter. Now, what is the functional state? Hyperthyroidism. Nodular. So I have not done my antibodies. I have done my uptake study. Uptake study is showing this. So what is the uptake study showing? Patchy uptake with hot and cold. Okay, so that is a toxic MNG. What's a etiological diagnosis will be toxic MNG. How will you treat her? You can start your treatment with antithyroid drugs. It's the same thing with non-beta blockers till radioactive iodine ablation is feasible. And if ablation is not feasible, please offer total thyroidectomy. Next case. Same patient. But again, I'm just changing male, female and all. But it's the same patient, same clinical picture. But on examination has a single nodular nodule in the right lobe. Reports are exactly same. Thyrotoxic, hyperthyroid. Ultrasound I did because there is a single nodule, which is showing a single nodule in the right thyroid lobe. Then obviously I have to do my uptake study. So uptake study is showing this. Becoming very easy. Correct. Very good. So this is showing focal high uptake with low to absent uptake in the remaining thyroid. What is the etiological diagnosis? Toxic adenoma. Okay. I was expecting to ask that question here, but this is the reason. The remaining follicles are TSH dependent and hence they suppressed. Okay. How will you treat it? Ablation or surgery. This is not a physician's case, but I want you to pick up all these things because patients with these uptake scans will come to you before you send them to a surgeon. Now, next case. 45, female, recently admitted in our ward and discharged with influenza, had a mild ARDS, didn't go to ICU. She's now come after probably a couple of weeks, 4 weeks later to my OPD, maybe, with weight loss and fatigue. And she's saying she's got mild pain at the neck. TSH is 0.001. Free T4 is 2. And your total T4 is slightly elevated at 50. Okay. Here, I checked my traps. I couldn't check my traps. Patients, test is not available. So I directly went and did a uptake scan. Now, before the uptake scan, what is my probable diagnosis? Before the uptake scan. So that is the one thing I forgot to mention in a clinical examination slide. Pain, thyroid region pain and thyroid tenderness are very important to be assessed in examination of thyroid. Why? The moment it is there, it has become thyroiditis. There are some thyroiditis which can be silent, but most of these thyroiditis are acute to subacute. Most of your thyroiditis are painful. So if you don't have pain, then you're thinking of autoimmune, chronic thyroiditis, things like that. So pain is very important. Pain, 2 to 3 months history or 1 month history, recent hospitalization for a viral illness a month ago with a hyperthyroid picture, then you look at the uptake. So what is this uptake? This patchy scanty uptake. You are not really seeing any hotspot anywhere. What's the etiological diagnosis? Subacute. Yeah, subacute thyroiditis. To call it decurrence, technically you need to have a biopsy, but subacute thyroiditis probably secondary to a viral infection. How will you treat her? Antithyroid drugs. Beta blockers, if they have very symptomatic. Do not stop giving that. But do not give any drug that alters your thyroid physiology. For the pain and the inflammation, you give them NSAIDs plus minus steroids based on how bad the inflammation is. Do not give anti-thyroid drugs for patients with subacute thyroiditis. You break the normal natural course of the disease where they gradually become hypothyroid to much an earlier dip to hypothyroid. Okay. That's a picture. So what is subacute thyroiditis? It's also called decurrence, granulomatous, or viral. It is a patchy inflammation, probably with some granulomas and fibrosis, and finally the thyroid gets back to normal. Now here the key thing is pain, goiter, fever. In the presence of biochemical thyrotoxicosis, in the presence of a recent infection, is subacute thyroiditis. Can happen through a thyrotoxic phase initially, then they go to a hypothyroid phase, then they recover. At this point, if we give them anti-thyroid drugs, this recovery will not happen. You will push the patient into a hypothyroidism. Treatment is high dose aspirate plus minus steroids. Absolutely no role for anti-thyroid drugs. What's the time? You guys can tell me to stop when it needs to be stopped. Our cases can keep going like this. 42, male. vision loss and decreased libido. TSH is normal, 2.2. But FT4 is 2.4, elevated. So this is that entity that I told before. Elevated T3, T4 with normal or detectable TSH levels. That's that box on the top right corner. Rings a bell? Now, a couple of other investigations in him. His prolactin was more than 10,000 and his testosterone is less than 20. That is because these are the two complaints he's mentioned. He's saying vision loss, so I check prolactin, and he's saying decreased liver, so I check testosterone. Now, what is the syndrome? The syndrome is what I mentioned. Elevated T3, T4 with detectable TSH. In an endocrinologist words, hyperthyroxinemia with normal TSH. That's the word Dr. Felix uses. Hyperthyroxinemia with normal TSH. What are your differentials here? A pituitary adenoma that secretes TSH. So TSH secreting pituitary adenoma or thyroid hormone resistance. How will you evaluate him? I will first do an MRI to look for a pituitary adenoma, which I think is what this gentleman will finally have in seeing at his prolactin levels. If that is negative, then I will look for a thyroid hormone resistance by doing a thyroid hormone receptor binding gene analysis. It's a mutation causing resistance. That's the most common cause of it. So just quickly looking into that entity called elevated T3, T4. First thing you should always do is you should always confirm these things with a higher good assay. Our labs use equilibrium dialysis for FT4. So very, very specific, very, very sensitive. Always rule out other diseases, intercurrent illness and all that. Now, once that is done, I am going to look at my pituitary. If there is an adenoma, I'm going to think in terms of a TSH secreting pituitary adenoma. If it is not, ideally, I can do a few other biochemical tests to prove thyroid hormone resistance, like TRH response. But you know that the most common cause of a thyroid hormone resistance is a mutation, and this analysis is commercially available. So you can do a thyroid hormone receptor binding gene analysis, which is seen in almost 90% of it. And that is tells you that the patient is having resistance to thyroid hormone. I have some more sections, but I'm cutting it in between. If you guys can arrange one more lecture, we can go through the remaining thyroid emergency, thyroid in pregnancy through cases, just like what we did today. But I think mine and yours time are slowly going away.
One more in the last case. Shouldn't the TSH, if it is a secreting adenoma, at least be on the closer to higher side of normal than on the very low side of normal?
That's what. So what are you defining as normal TSH, my friend?
Yeah, that's
so for an individual, it is very difficult to say what exactly was his normal before to become that. So that is why interpretation of the whole thing has to be interpreted in totality. You cannot interpret thyroid function test by one test. And if there is one test, that one test is TSH. Okay. Hopefully we have gone through all possible permutation combinations of things. All these are made up patients. None of these are my patients. Just for learning. Any questions?
Drug-induced
Yeah, so that depends on the drug. Okay, so there are a couple of common entities that I have not involved, which is quite important, but we don't have the type. Like amiodarone-induced hypothyroidism, it's lifelong. It depends on two types. So you have type 1 and type 2. Type 1 is okay. So they titrate, they try to stop. Type 2 is deadly. It's a lot of fibrosis, lifelong supplementation. The same thing with immunotherapy. Immunotherapy, if you have a hypothyroidism, once you stop your immunotherapy, in 6 months' time, you have to recheck your antibodies, TSH, and you can slowly stop it. It's not a lifelong therapy. But the problem with a lot of those things are, they usually are on these medicines for a long time. It's not just immunotherapy. Even your tyrosine kinase inhibitors can also cause hypothyroidism, vitiligo, hypothyroidism. But it is very, very common. Like from somebody who's worked in oncology for some time, If your patient is on immunotherapy, and if he's not really developing hypothyroidism, and sometimes you're really not sure of if he's really taking it, because invariably it causes hypothyroidism. Very common. One of the most common IRAE, immune related adverse effect, is the word they use for all these side effects. But very common. And usually counseled in the beginning of the treatment only. Please read up about amiodarone induced. I mean, there's no time to put everything. The more I put, the session is just going to get longer and longer, so it's not going to help me. Okay. If interested for a further session, we can start from here. There are many more. I'm not going to. Or since we spoke all this, let's just quickly see the thyroid storm and go. No? Since I said all this, I think that's probably one of the most deadly things you see in the ward. Ideally, thyroid emergencies will include thyroid storm, mixed edema coma, and Hashimoto encephalopathy, which is otherwise called as steroid responsive encephalopathy with autoimmune thyroiditis, SRIAT. Okay, of which thyroid storm is very common and something that has to be picked up. So we'll just quickly go through a case. Hopefully nobody is getting bored. 33 female, 3 months weight loss, diarrhea, palpitation, but 1 week breathlessness, orthopnea, pedal edema. Examination: tachycardic, tachypneic, features of a high output failure, and mild exophthalmos. TSH less than 0.01, FT4 4.4. In real life, don't do, but for making the case more clear, NT-proBNP 8,500. And a smart postgraduate who did a TSH receptor antibody positive. Oh, answer came with it. Okay, my bad. So what is the syndrome? Here you have a syndrome is thyroid. When do you suspect thyroid storm? So when you have thyroid toxicosis with GI or cardiac symptoms is when you start thinking, oh, is this patient going into a thyroid storm? How will you confirm the diagnosis and assess the severity? Borch-Wartnowski score. And how will you treat? Three cornerstones of treating thyroid storm. One is beta blockers. 2 is anti-thyroid drugs. Remember, PTU is preferred, but nowadays people say even carbimazole is as good. And hydrocot. 3 pillars of managing a thyroid storm. And supportive care for your organ dysfunction, obviously. Okay, I'm going a little fast so that you can. Now, what is thyroid storm? An acute life-threatening syndrome due to an exacerbation of thyroid toxicosis. Usual precipitants are infections, acute illnesses like MI, strokes, a non-thyroid surgery in a hyperthyroid patient, somebody who is on anti-thyroid drug who discontinues, somebody who takes radioiodine therapy, iodinated contrast, etc. What are the clinical features? Usually thyroid storm is associated with goiter. You usually have a fever more than 105, marked tachycardia, high output heart failure, tremor, sweating, agitation, and finally leading to delirium and coma. Now, this is a picture that shows your Borch-Wartnowski score. The picture is here. The score is, I mean, I don't think we should by heart the score, but remember the components of the score that makes the patient sicker. So when you assess the patient, these are the things to look for. 1, is there a history, precipitant history? Is the patient in heart failure? What is my heart rate? What is my GS function? What is my temperature? And what is my sensorium level? These are the 6 or 7 things that are used. And anybody who gets a point score of more than 45 is considered to have a thyroid storm. Okay. Now, quickly going on to management, I told you those are the pillars of management will be beta blockers. The more commonly used is propranolol. But in an ICU admitted patient, if you want to give an IV beta blocker, you can always give esmolol. Next is anti-thyroid drugs. According to American Thyroid Association, you should load propylthiouracil, then give 250 Q4H. Most other recommendations say that you can just start 250 milligrams Q4H. Something else that is there is if it is not getting controlled with this, 1 hour after you can give potassium iodide. We usually don't give this step. The last pillar is hydrocot. Give a high dose, 300 and then 100 Q8H. There are some more. Sometime later we can go through. Pregnancy also, hopefully we can go through some other day due to some cases. Thank you.
Thank you.
Online.